This is CCTA case number 18. The history is that of a 78-year-old woman with some new onset chest pain and shortness of breath. She has a known history of a reduced ejection fraction and a status post biventricular pacemaker insertion. There are 3 phases for review, and these can be changed by looking at the Cine controls and using either the next or the previous button to review each of these. It's a difficult study to evaluate. Let's take it individually. Let's first of all look at our left main coronary. Centering it in the crosshairs, this appears to be normal. Let's begin now by looking at the left anterior descending. You can clearly see some eccentric non-obstructive plaque involving the proximal portion of the left anterior descending. So we proceed down the remainder of the vessel. There is some more calcified plaque further down, a bit more difficult to evaluate in this region. Let's see if another phase will help. Difficult to evaluate whether any of these phases works. Let's switch from a 5mm MIP to an MPR view and try to look at this a little bit better. As you rotate around here, you still get the sense that there are some artifacts. The pacemaker, which is sitting in the anterior cardiac vein, can be putting some artifacts in that area. But if you look at the coronary itself, this appears to be clearly non-obstructive disease. Let's switch back to a 5mm MIP. Proceed down the remainder of the vessel. So we have non-obstructive disease in the proximal and mid portion of the left anterior descending. Let's take a look at the circumflex vessel. Rather tortuous vessel. Let's see if we can follow this down. Here is part of the pacemaker lead that's crossing, coming from the coronary sinus up to the anterior cardiac vein, but the circumflex vessel itself appears to be unremarkable. Let's proceed down the obtuse marginal branch. Again, relatively normal. Tortuous vessel. There is clearly some non-obstructive eccentric plaque in the distal portion of the left circumflex vessel, but nothing that looks, frankly, obstructive. Let's switch to the right coronary artery. This one's a bit more difficult because this is part of the lead of the pacemaker. These are pacemaker artifacts. Sometimes changing, broadening out the window, going to a lung window evaluation can sometimes be helpful. This becomes a difficult situation. You have to kind of think about the possibility as to whether or not there can be any significant disease in this region. Difficult to evaluate as we proceed down the remainder of the vessel. Clearly diffuse, calcified, eccentric, but non-obstructive disease involving the right coronary. This area continues to be a bit of a challenge. Switching to another phase may help a little bit. Switching to an MPR, very thin view here. Frankly, this is a classic thing that we see with motion artifacts. I really doubt if there's any significant disease in that region given the view of the rest and remainder of the vessel. Let's take a look now down at the most distal portion. We proceed down here. We can see the artifacts from the pacemaker. We're down here in the distal right coronary. Otherwise appears to be normal, and there's a small but normal posterior descending artery. Now, a couple other features here that are important to evaluate in this individual. First of all, you can see that there is some mild pericardial thickening in the anterior portion. This is relatively common and does not really represent any clear pathologic state. As we go up and down, we're struck with the idea that the left ventricle is significantly dilated. It also appears that the left atrium is as well dilated. If we move this up to the center here, we can get a general idea of looking at the left atrium. If we pretend to be an M-mode echo, we can then do two-dimensional measurements approximately in this area, get an estimation of the overall size, getting about 46, 47 millimeters. Upper limits of normal is about 40 millimeters. So this is mildly to moderately dilated. Also like to get just some general idea of the overall size of the left ventricle. This is best done by actually going to the heart view. We're going to go to a 2x2 display here, and then we're going to hit the heart view tab and try to get this set up in the proper axes. We now have this set up in a standard cardiac axis. We have in the upper left the horizontal long axis, in the lower right we have the vertical long axis, and in the middle we have the mid-ventricular short axis view. Best way to at least get an estimation of overall size is to use one of the long axis or short axis images. I'm going to concentrate particularly on the short axis image. I'm going to expand that to a single view. I'm going now to make a two-dimensional measurement of the left ventricle. I'm going to go to the edge here and then pull up the menu. Two-dimensional view here, extending over to approximately, go across the short axis view. We're getting a measurement of about 72 millimeters. So this is a significantly dilated left ventricle. Upper limits of normal is about 55 millimeters in this axis. So in summary, we have a 78-year-old woman who has what appears to be a non-ischemic dilated cardiomyopathy with no evidence of obstructive disease at the present time. She's got some mild pericardial thickening, and she has evidence of a biventricular pacemaker.